So we're going to take a case. I'll give you buzzwords, signs and symptoms, how to treat it, and you will figure it out in the middle of the case. So let's take a look at it. What is the problem? We're dealing with a progressive, degenerative, is a neurological issue. Those are buzzwords. It's progressive, it's degenerative, neurological problem. Why? Because of this substantia nigra. This is a portion of your brain. It's responsible for producing specific neurotransmitter. These neurotransmitter usually it slows us down. So it's supposed to slow us down. And these neurotransmitter inhibit another neurotransmitter. It's acetylcholine. You figure out yet? It's a puzzle. It's in the substantia nigra, portion of the brain. So that neurotransmitter is supposed to slow you down, and it's supposed to inhibit acetylcholine. Acetylcholine speeds things up. If there is imbalance between this problem, between the neurotransmitter from the substantia nigra, I'll call it SN, and acetylcholine, we have this structures called Lewy bodies that will build up in your brain. And affect two things, your cognitive function and your motor function. This is how you do case study. You see, I'm not giving you what is the problem. I'm giving you signs and symptoms, key facts about the problem. They go through stages. Type 1. First stage. I know somebody will present the signs and symptoms to you and you can figure out. But first stage, what happened to them? They have unilateral limb movement, one side. That's their problem. That is type 1, early stages of the disease. Then type 2, that means it's getting a little bit worse. You see some gait problem. And both limbs, so bilateral limbs are involved, and it affects their face. Any clue? Then when you get to the third stage, you have postural problem, instability. They're going to fall. No clue? And normal fall, they start having rigidity. And akinesia, basically, no movement at all. Does it ring a bell? Neurological problem. This is what I'm doing in such a way that you will be able to confuse it with any other neurological problem. You have rigidity. I know there's acronym there that you always recite, rigidity and akinesia. And when you get to the stage 5, they are fully dependent. So their ADL is all dependent on a caregiver. Neurological problem, degenerative problem, is progressive, substantia nigra problem. We have imbalance between acetylcholine and then that neurotransmitter. Their cognitive function is affected. And he undergoes so many stages, 5 stages. At stage 4, they have rigidity akinesia. And 5, they have to depend on somebody. Something should be ringing in your ear right now, and you'll be able to figure out this problem. So these imbalance will lead to this problem. We have tremor, and this tremor is resting. And you see some pill rolling signs. I know you're getting it right now. That's the first one, right? Then they become rigid. That's the stage 4, rigidity of the muscle. As you become rigid, you're not going to move. So you're going to have akinesia or slow movement, bradykinesia. You don't have to memorize it. If you can't move and you have akinesia, you try to support yourself. So you stood up forward. In that problem, you have postural instability. Your center of gravity will shift. And this is the acronym everybody knows about, right? T, yeah. Let me make it. So there's T, there's a R, there's a A, and there's a P, right? You've seen it before. Everybody know about it. I know by now you figure it out. Then, let's look at it. There's a Hallmark signs about this problem. They have a Hallmark signs. Everybody know about it. The tremor is going to be there, but like I told you, it's a resting problem or pin rolling tremor. Because the gait is affected and they cannot move, they will shuffle it. They will move the whole body at once so that they don't fall, shuffling their gait. That's what they're trying to do. If you shuffle your gait, you will not be able to stop if you want to. So they have a problem. They lose the ability to stop right away. Right? It's a muscle problem. They start tensing their body. If you tense your body, look at your face. Look like you have a mask on. And because my gait is disturbed, I move forward to support my center of gravity. So stoop posture. That's the Hallmark signs. You figure it out now, right? Therefore, what is the issue? What is the issue? If I said, take care of this patient, what is your issue? Okay, this is a case, short case, trying to give you next generation. When you're reading it, that's the way you try to like make sense of words. You're looking for words. So I'm giving you words you can put it together, and then you can figure it out like, oh, this is what they're talking about. There's a bunch of problems with progressive disease, but what is going on, right? Therefore, what is that neurotransmitter? What do you think? It's dopamine. And he has imbalance with acetylcholine. And these dopaminergic neurotransmitters in the substantia nigra will give you these classic symptoms of somebody who is trapped in their body, basically, and they cannot move the way they were supposed to move. So what is your issue? Don't memorize what they need. Look at the signs and symptoms I've given you. They have a posture problem, right? So which is going to be stooped, right? That's the first problem. Their gait is in trouble. What is their gait? What did they do with their gait? I told you, right? It's shuffled. And they have difficulty stopping. And they have motor problem, bad rigidity, tremor, resting, and a max-like face. The motor problem put them at risk of this for biggest problem of this disease. That is the biggest problem of this disease. What is going to be your B-sharp moment? What is going to be your B-sharp moment? The dopamine is affecting every muscle in the body. So what is your B-sharp moment? That means what is your priority for this particular patient? What is your priority? What should you pay attention to if they give you which of these patients? If I give you a bunch of these patients, particular problem, who is going to be your priority? Is somebody who speech muscles are affected, airway muscles are affected. Those are the patients you pay attention to. Their muscles of the airway is going to be affected because the disease process is affecting every muscle in the body. So speech, you're looking for the word dysarthria. That's your buzzword. If you see that, or slow voice, you know that's your B-sharp moment. So slow voice is something you should never let go. That's your priority patient of anybody with this problem. If they have this, it's a priority patient. Then think about it. Your muscle, your vessels, they have muscle in them. So vessels also have muscle. So if this is the vessel, let me use red. If this is the vessel, they have muscles around it. That is what causes contraction. We have a muscle problem. The muscles lose their tone. So they lose their tone, and that causes the autonomic dysfunction in this patient. What does that mean? You have orthostatic hypotension. These also add up to their problem. You see, one problem, a bunch of stuff. And the worst of all, is the mental health issue. Watch for this in your test, depression. They are unstable, emotionally liable. They will just basically flip up back and forth. So you have to pay attention. So they can also have some psychosis. Very, very important. I know you figure out by now. So that's the issue that you have to deal with. If you are the nurse, what is your focus now? What are you going to be focused on? Now you got to treat this patient. Usually there's no a lot of lab work. You can get a CBC to look for anemia of the chronic disease or BMP to check the electrolyte, but there's nothing. You can get an EEG and to see the brain function, how much Lewy bodies is deposited. But your job is to treat this patient. So that is the next job. If you're taking care of this patient, what do you think? What kind of people do you need to help you? They are in your hospital. Based on the signs and symptoms, what do you think you need to effectively take care of this patient? You have to focus on the things that we talk about. So what do you think? What do you think you need to have to be able to take care of the patient? One of these biggest problem is fall. So what will you institute at home, in the hospital, to take care of this patient who may have a fall? Fall risks, right? So you got to do things. What do you think, guys? What are you going to do? I think they should have non-skilled shoes on, right? Or socks. Because they're going to be falling and they're shoveling their gait. You tell them to swing. They don't want to swing their extremities because they are afraid of falling. So, but that's the problem. Take long steps. Tell them to take a long steps and swing your arms. Okay, that's what you tell them. Swinging is good for you. That will keep you balanced. You should not leave something on the ground. What do you think? There's something you should not have it on the ground, otherwise they trip on it. So era rags, take care of it. These people cannot depend on you forever, right? Provide some assistive devices. You know them. If they have a shoe, make sure there's a Velcro on it so that they don't have to worry themselves, right? What else will you do? The toilet, what else can you do in your house to help with them? What do you think? There has to be some modification in your house to help with the situation. So you have to make certain changes. The toilet seats shouldn't be lower. They're going to fall, right? Elevated. Toilet seats. They may need a walker. PT can provide that. They may need cane. Whatever you need to support this patient. And of course, cluster-free environment for them, right? Of course, physical therapy, occupational therapy is going to be there. I told you their biggest problem is what? What was the biggest problem? What do you worry about? You, the nurse, that is going to kill them. Their B-sharp movement is what? Airway, right? Those airway signs are the dysarthria you talk about. We talk about, and change in voice or swallowing. So what do you want to do? You are the doctor now. What do you want to do? You are the nurse. What do you want to do? This patient, they are risks of what? Airway. And so they have dysarthria, change in voice and swallowing. What would you do? Institute in your plan as a priority when these patients are admitted in your hospital and you're taking care of them. What would you do to prevent the airway problem? Think about it. What would you do? What can you institute? Who are you going to call to help you with this problem? The airway issue. Remember, it's not the breathing problem. It's not like they can't breathe. They can, but there's something related to the dysarthria. So, involve speech. Speech evaluation. They are your friend. Speech therapy. And swallow. So that they can do swallow steady, and that will help you. Don't forget speech therapy. They will do swallow steady so that the client does not aspirate. That's your biggest problem for these patients. Aspiration is number one. If they are risks of aspiration, how do you want let them eat. What kind of strategy you want to institute? What kind of strategy you want to institute? Right? I'm at risk of aspiration. Therefore, I'm going to try to do what? Small meal, small frequent meal at a time. No large meal, small frequent meal. They are very, very slow. So you should give them time to process stuff, process information. Very key for these particular people. Their GI tract is not going to work the way it's supposed to. Right? Constipation is their biggest problem also. But that's not a B-sharp moment. Constipation. So what do you want to do about it? Constipation. What do you want to do about it? This particular patient has constipation. I'm telling you how they can take you everywhere in this case study. If they give you, they'll take you everywhere. What do you want to do about this problem? What are the three things? They cannot do all of them, but you can help with that by let them do what? Drink a lot of water. At least 2 to 3 liters of water a day. Then what? Give it some high fiber diet. They can exercise. Just because they have all these problems, institute exercise. So according to AMA, these people need to walk 4 times a day. And that will help them with constipation. Very, very important. Don't forget about the caregiver. When they ask you a question about constipation, stool softener is never an answer. Stool softener does not prevent constipation. Once again, stool softener does not prevent constipation. It treats it. What prevents constipation? A lot of water, fiber, and exercise. Don't let them trap you. Stool softener, treat. We don't want to treat it. We want to prevent it. So we want to prevent it. We want to prevent constipation, but not treat it. So treatment is different from, so stool softener is always treating the problem, but not preventing it. So we want to prevent that. Okay, that's the difference between this problem. So just do those fiber, hydration, work, and exercise will help prevent that. Don't forget the caregiver. They're going to be tired. They're going to be mad. They will not be happy all the time. What should you provide therapeutically? If you see those signs, what are your interventions? What one thing can you do that you can provide some help for that? What do you think? What one thing can you do to help with that? What kind of referral would you make? That's what you do. Respite care for the caregiver. So don't forget about it. So we know the problem. We know the problem. And the problem, you guys figure it out. I saw the answers. Parkinson. So you guys figure out the problem. And so we have to treat it now medically. Go back to the pathophysiology. What is the problem? You have one neuron here, another neuron here. This is acetylcholine, and this is dopamine. Dopamine is inhibiting negative. It's blocking acetylcholine. So the acetylcholine is down, because if you let this up, it ramps things up. Therefore, either I block this, the acetylcholine, or I give you more dopamine. That is all the disease process about. You think about it, I have imbalance. So I got to increase my dopamine and I got to decrease my acetylcholine so that the function that acetylcholine is taking over, the dopamine can do that. It can reverse it. That's all. So I need to give you dopamine. Remember that dopamine is a monoamine neurotransmitters. So you can give them, and they are broken down by monoamine oxidase. So to destroy dopamine, you need monoamine oxidase, where I can inhibit this oxidase and I can put monoamine oxidase inhibitor. Have you heard it before? What is that? MAOIs. You heard it before, right? You know that. You can use MOAIs that we use for depression for people with what? Parkinson disease. And that will prevent breakdown of dopamine, so you have more dopamine. The common one they use is serotonin. So if you see a question like that in a dopamine Parkinson patient, yes, you have to. You can use that. And the other one, this is specifically, it's a monoamine inhibitor for Parkinson disease. Now we're keeping the dopamine more. We're preventing the dopamine from getting broken down. We can also give them dopamine. Why not? Just give dopamine. So dopamine agonist. That's all. It acts like dopamine. You've seen this medication before. You got to this one. You have to know this medication. You be familiar with it, that it exists, right? Ropinirole. There's two of them, and his other friend is pромiprazole. These are all used in Parkinson. They are dopamine agonists. And the most common one we all know is levodopa, carbidopa. Everybody know about it, right? Levodopa, carbidopa. We all know about it. One, this is a carrier. It just prevents the levodopa from being broken down. But he has a dopamine, it gets broken down into dopamine and it does its job. So these are dopamine agonists. So these are a class of medication you have to know. These medication hate protein. So you have to hold, if you're on 2 feet, 2 hours before you give the medication and 2 hours after. If they're not on 2 feet, don't let them eat large protein diet before you give it to them. That is the key. It causes orthostatic hypotension. It makes the urine change. It has other side effects. When they become bradykinesia, they move forward. Now you give it to them, they start to move so fast. That's when it becomes a side effect. But these are medication you can use. Now, look at it. The third one, what do you think you can do? Based on the pathophysiology, it's either we give more dopamine, we prevent dopamine from breaking down, or we have too much acetylcholine. So what would you do with it? What do you think you should do with the acetylcholine? Pharmacology, you don't have to memorize. I think pharmacology is the basis of medicine because I call it pathophysiology. If you know the pathological problem, you can the manifestation physiologically. If you want to fix it, go to the pathology and fix the problem. We know we need more dopamine, so we give dopamine agonists. We know we need more dopamine, so we prevent the dopamine from breaking down. We know we don't need acetylcholine. We have too much acetylcholine. What do you want to do with it? What can you do with it? What do you guys think? What can you do with the acetylcholine? What would you do? You have so many options. What do you think is the most common thing we can do? We have so much options, so many options. You can block it, right? Block it. When you block it, what do you call it? Anticholinergic. The common one that we use is benztropine. Or try HESI. This one, in case you see it, phenidol. These are the common one we use for Parkinson patients. All we're doing, we blocking the acetylcholine effect. Don't forget, they can ask you a question on that. What is the signs and symptoms we're going to have? Dry mouth, right? Constipation, dry eyes, right? Urinary retention. But what is your B-sharp moment? When you give somebody anticholinergic, all these problems, you can fix it. Dry mouth, sugar-free candy. Take some sugar-free candy. Constipation, some fiber, water, and exercise. Dry eyes, eye drop, right? Urinary retention. We just check if we have to place a Foley, we do. But what is the most serious of anticholinergic? You got to watch if the patient has glaucoma. If they have glaucoma, yeah, it causes pupillary dilation, so you have to be careful. So when I give you a question on anticholinergic, watch and see in the question from the patient has a eye problem. If they have glaucoma or eye problem, anticholinergic is not your friend. And the last thing you can do is nerve stimulation to help with that. There is a situation they can ask you. So if this patient have psychosis, okay, they can have psychosis, like I told you, emotional problem, psychosis. How would you treat it? Remember, they have psychosis. You can make sense out of it to the what I've described to you. They have psychosis because of something. Why? They will get psychosis when you're treating them. When you're treating them, they get psychosis. Why? How did they develop psychosis when you're treating them? What do you guys think? How did they develop psychosis when you're treating them? It's because, what are we giving them? Look at all the things we're giving them. We're giving them what? We're giving them too much dopamine. Dopamine is the biggest that play a role in schizophrenia or psychosis. So excessive dopamine is the problem. But they need the dopamine to work, to do their thing. So you want to take it away? So they are psychosis. We give them too dopamine. How do you treat it? You got to give them something. This is the key. You don't want to block all the dopamine. You block enough. Block enough. So dopamine play a role in psychosis. So most antipsychotic block dopamine effect. Which one? First generation. The first generation antipsychotic, they block dopamine. Second, they block serotonin. So if they give you a choice, which of these can you use in Parkinson people? Never pick first generation, because then if you block their dopamine, you put them back in the Parkinson state. You make their symptoms worse and worse and worse and worse. So if you have a choice, if they have psychosis or you have psychotic problem, you shouldn't choose first generation. Do not choose. So this is no. Do not choose first generation. Select. This is your choice. Select this one. Second generation antipsychotic. And you know them. Clozapine, right? Risperidone, or the olanzapine. Yeah, don't give them allopuridol or fluphenazine or the first generation antipsychotic. Stay away from it in the Parkinson patient, because you're going to worsen their situation. You're going to block all their dopamine. They need the dopamine to be able to function. When you treat them, you give them too much dopamine and you push them over edge, they have psychosis. So if you have to block it, use second generation antipsychotic to treat the psychosis, which is clozapine, quetiapine, olanzapine. They have the last name, the dons, right? Risperidones, and they have the same thing. But the first generation are dangerous for these people. I'm glad you guys were able to make the diagnosis. This is the way you present this disease so that it become friendly. It's not just so that you can understand where everything is coming from. And you wake up in the morning, you can figure it out. Like you understand, oh, this is what it is. It's not just telling you about trap. No, there's a reason why they trap. It has to make sense. They trap because there's something going on neurologically in the substantia nigra, and that is blockage and atrophy of that problem. And the reason why acetylcholine took over, because of the inhibitory effect. And the reason why we give them dopamine is this. And you have so many options. Either you increase the dopamine, you give them agonists, or you block the acetylcholine. There's so many nursing intervention you have to do. They are very special people. They can affect young people and older people. So this is a disease process everybody should be working on to take care of it. I think it's very important medical problem. Unfortunately, when you get it, it's not fun. But you can see everything is affected, and you should be able to distinguish it between GBS, ALS, all of them, because of the way it's presented. Remember, your B-sharp moment is what? Airway. And airway, always pay attention to changing voice and dysarthria and slurred speech. That means that airway muscles are affected. This is the end of the lecture. Thank you for sticking around with Adapt NCLEX. If you don't subscribe, just look down and subscribe, support the channel, check Adapt NCLEX. You get more content like that. Thank you for spending your night with me. All the best of luck. Any question?